We're now going to talk about the what, when, and how of documentation. So I first want to go through some of the information again that you read in the medical documentation for athletic training paper that was in this home study. And so we're going to talk first about what a patient encounter is. And I think this is important to first identify and define as we get into some of these what to document. So the way that the work group wrote it is a patient encounter is defined as any interaction with a patient when an athletic training service is provided or communication occurs. Communication is and is not limited to written, verbal, or electronic communication with an individual or entity. So let's think about the patient encounters that you see. So when people come into your athletic training facility and are asking for any sort of advice on an injury, this is still considered a patient encounter. So please keep that in the back of your mind as you're going through about what should and shouldn't be within the medical documentation. Additionally, something that needs to be documented is this change in a patient's status. So anytime that there's a change or a deviation other than the expected, this is when a complete evaluation should occur, including any sort of consultation or a measurement of status change. So we can think here about our clinician-reported outcome measures and our patient-reported outcome measures of things like range of motion, or maybe you use a generic one like the RAND 36 to see how a patient's health-related quality of life is affected. And so anytime that we have any of these informations, that's considered a change in patient status. And a lot of times this is where we think of our daily notes, but this doesn't necessarily have to be as in-depth for the daily notes. So we know that anytime a large patient change happens, that we need to complete another evaluation for the patient at hand. We're going to start with the initial evaluation, and I put up here the traditional subjective objective assessment plan. And there's a lot of controversy between, is this something that should be used or not? And I don't think that I am able to fully give you the best answer for this. I think it depends on what your setting is and what you're doing. So if you are working with an electronic medical record, the likelihood that you are going to see subjective objective assessment and plan is very minimal. Most likely you're going to see something that goes through and talks about maybe specifics. So maybe it'll ask you where the patient was injured, what body region, then specifically what segment of the body, and then it may go into specifically what injury do you think it is then, right or left side, questions like that, rather than the traditional what we were all taught, SOAP. But I still think it's important to know the different parts of the SOAP note in order to get a good understanding of what is included within medical documentation. I also understand that some of you are still completing pencil and pen documentation, and this may be the only way that you are able to complete the encounter that you had. So in the subjective part, these are a little bit, have a little bit of continuity between the different places, so keep that in mind. But within subjective, when we're talking about what we see. So if you're coming and you notice that the patient's limping into your athletic training facility, that's something that's in the subjective part. And so if we know that the patient is showing maybe reporting a pain that's 5 out of 10, this is kind of one of those gray areas because it is a outcome that could be completed within the objective. But there's also no way of me saying, okay, this is exactly what a 5 is, so I'm going to put this in a very specific category. And so subjective is normally that background of what happened, what are they complaining of, anything else that you need to report about the encounter. As we move into the objective part, this is those specifics. So these are clinician rated outcomes such as range of motion, manual muscle testing, any sort of other patient-reported outcomes that you complete. These all go in that objective spot. And within this objective spot, things should be quantifiable. So when we are talking about range of motion, I do not like to see, and especially when I work with my students, that their left hamstring extension, so hip extension, was within normal limits. And so as we're thinking about that, what is normal for that patient? Do we check both sides? I would rather have a goniometer out and say, I got 15 degrees of hip extension from this patient. And so being able to have that quantifiable information to go back and recheck the information and reassess later is very important. We can also do things such as swelling. So instead of just noting that there was swelling within the joint, using maybe like the figure 8 method around the ankle or having a tape measure with specific measurements around the knee is important to be able to know if there is an improvement. Then we go into our assessment, and this is something that a lot of people still struggle with within athletic training. We are allowed to give a diagnosis within athletic training in almost every state that we work, depending on your state's requirements. So oftentimes in this, do I think that you're going to be able to get the assessment every time? No. Do I think that you need to have a differential list that you have determined what could be wrong with the patient? Absolutely, because we need to be able to take that information and move on. And the last part that we're going to talk about is the plan. And this is something that oftentimes I think gets kind of overlooked. So within the plan, we want to look at the patient as a whole. So oftentimes as athletic trainers, we think, okay, my patient is a 22-year-old soccer player, and their main goal is to continue to play soccer. Well, that might not be their main goal. Maybe they hurt their shoulder and are concerned that they're not going to be able to help their parents who are a little bit older and aren't able to get around. Or maybe they're concerned that that ACL tear that they had in high school with a re-tear their freshman year is going to turn into osteoarthritis and they won't be able to run around or play with their kids. And so I think we need to talk right here specifically for patient-centered care and to note in the plan exactly what that means for the patient. Will that mean return to activity sometimes? Yes. Will that also sometimes be a combination of return to activity and return to activities of daily life? Absolutely. And I think it's important within this to think of those SMART goals that you created. So having something specific that they want to do, make it measurable. So make it so that way they have short-term and long-term goals so they're able to get back to their activity. That they have a specific thing that they want to get better, that it's attainable, realistic, and that it's also timely. And so thinking of these different aspects, what is best for this patient at that time? And like I said earlier, think of both long and term short goals, because you're going to want something that the patient can do right then and there and can reassess every couple of days or every day and slightly get better. And then you're going to also want those longer goals. We're going to talk about some common errors in the initial diagnosis. So within this, a few of the common errors are failure to include the visit number. So if this is the very first time that John has walked into the athletic training facility to have this ankle injury evaluated, this is going to be the first one. We also know that people often forget to put treatment times in minutes. So if you performed, I iced him on a patient for 10 minutes on his right hamstring, that needs to be listed. Additionally, signing and dating entries is very important, and we often believe that electronic medical records are just going to take the place of this, but that's something that we need to make sure that we are not just relying on, that we are going in, if a student worked with us, I need the student and my name as the certified and the date that we did this. If anything is incorrect and you have already stated that medical documentation, you should never go back to that initial evaluation and change it. Put a new note in and state what the error was, maybe what the additional change was, and then sign and date that one. Like I said, documenting treatment, modality, procedures. If you're using any modalities or treatments, the parameters need to be listed. We also fail to reassess objective goals and data. So going back through and saying, hey, we wanted so you could walk up the stairs today without pain. Did you meet that? We also know that there's oftentimes a lack of a skilled assessment, or if we do things such as non-diagnostic, non-therapeutic, or repetitive. So don't have your patients go through the same exercises every day. Be able to give some more evidence